All right. Hello, everybody. Hope you can all see and hear me okay. Certainly, if there's any technical issues, please post it in the chat. My name is Chris Urbanek. I'm a physician at the Regenexx Des Moines Clinic, and this is kind of the return of our lunchtime webinar that we're going to be talking about what we can do to help our patients. So our topic today is going to be going over shoulder injuries with a bit of a focus on rotator cuff tears and kind of how our treatments can benefit patients and potentially save from surgical intervention. So if throughout the talk you have any questions, please put them in the chat. We'll be doing a little bit of a Q&A afterwards, and so we kind of discuss this, and we'll make sure that we hit any of the pertinent points that that y'all are interested in. So with that being said, we're going to open up our short PowerPoint, and we'll kind of go over a little bit of our talk today. So. Wonderful. So again, my name is Chris Urbanek. I'm a physician here at our Regenexx Des Moines Clinic, and we'll be talking about the shoulder. So this is a super busy slide, and that's intentional. It's because I really want to impress the complexity of the shoulder joint. So when a lot of people talk about shoulder, there's really four main joints. And so kind of on this PowerPoint, you can see that, there's the arm bone, and where the arm bone meets the shoulder blade is really the main shoulder joint. This is what gives us our motion, raising our arm overhead, reaching out to the side. And then there's really three other joints. There's the bone where the collarbone meets the shoulder blade up top, the AC joint or acromioclavicular joint. There's the joint where the collarbone meets our sternum, not depicted in this picture. And then there's the joint where the shoulder blade actually meets up against the back of the ribs. And so that's not what we call a diarthrodial joint, or what we commonly think of as joints, but it is an articulation between the two. And so all of those things can cause issues as far as pain around the scapula or shoulder. But our focus today is really going to be the rotator cuff tendons. And so on both of these pictures is a front and back view of a shoulder. In the very, very front is the shoulder blade. And so this is the big kind of triangle shaped bone. The front side of that is the subscapularis. So this is our rotator cuff tendon that allows us to internally rotate, to bring your hand towards your belly button. And then there's a rotator cuff tendon that sits along the top. That's our supraspinatus. That's the one that's most commonly injured. And then on the back side, there's two other tendons. There's the infraspinatus, as well as the teres minor. And so all of those two work in concert for essentially external rotation. But again, my point is you can see all of these other structures that are involved. The joint can cause pain. The glenohumeral joint can cause pain. The acromioclavicular joint can cause pain. The biceps tendon, which splits into a long and a short head on the front, can cause pain. In this kind of purple color on the slide, this is your bursa. So if you hear people talk about shoulder bursitis, that's the part that gets irritated. And so the kind of complexity of the joint lends itself to pain that's sometimes tricky to figure out by physicians, and stresses the importance of really why you need a good thorough musculoskeletal exam to sometime tease out why that is. This is kind of a nice view of a rotator cuff tear. And so again, we're looking at a similar structure. You can see ribs wrapping around the front side. That front rotator cuff tendon, the subscapularis, is intact, touching the arm bone. And then up top, underneath the collarbone, underneath part of the shoulder blade, is our supraspinatus. And in this picture is kind of this full thickness tear. And that's really one of the things that I wanted to talk about is, there's a spectrum of pathology when we talk about the rotator cuff tendons. On one end, there's the more mild symptoms. When we talk about tendinopathy, tendinosis, you may hear people say tendinitis, which is more of an inflammatory condition and less common than the typical tendinosis, which is the wear and tear of the tendon. And then beyond that, we get into this whole spectrum of tears. And some of them sound really scary, right? What, like a full thickness rotator cuff tear. But what is that really? So this is a full thickness, meaning from the bottom of the rotator cuff tendon to the top of the rotator cuff tendon, it's no longer intact. But this is also a full width tear, meaning from the posterior side, the back of the rotator cuff tendon, coming all the way to the front, is torn as well. So as we're kind of having conversations with patients and talking about their, how bad is the shoulder, one of the things that I like to focus on is kind of those two dimensions. What's the width of the tear? Does it go from bottom to top? Or is it just a top-sided tear, bursal? Is it just a joint-sided tear, articular? Or is it a tear inside the tendon, which we call interstitial? And then even beyond that, as we kind of define what a full thickness tear is, you can have a full thickness tear, meaning from bottom to top of the tendon is torn, but it's maybe only a millimeter wide. So it's a very narrow width tear. And so that's one of the things that can certainly be involved in decision making. How big is the tear? How much space does it take up? So if I have patients telling me, oh, I've got a full thickness tear, that still doesn't give me all of the picture. I need to know how much width of it is it? Does it go forward and extend into the subscapularis? Does it go backwards and extend into the infraspinatus? So the isolated full thickness tear just by itself doesn't give us kind of the full picture. Now, the other side of that is you could have a partial thickness tear. So as I was saying, just affecting either the articular side, the bottom half of the tendon, or the bursal side, the top half of the tendon, and that tear may be full width. So it goes from front to back of the tendon. And I would get much more concerned about that because you could potentially lose more of the force transfer, the ability of the muscle to move the bone, because there's less tendon intact, even though it's a partial tear. So we really, the verbiage is actually important in this and kind of communicating to patients, physicians, or peers as far as what extent of the tear that there really is. And a lot of that can come down to our imaging modalities. How do we image the rotator cuff tendon? What are we looking at? And so with all of our patients, we do ultrasound on. And so I don't expect you to be practicing radiologist, but the picture on the left is a MRI of the shoulder. And so you can see the ball and socket joint where the arm bone meets the shoulder blade. That's the glenohumeral joint, the main one. There's a little bit of white fluid at the bottom. This was a contrasted study. And so that white is very bright because of that. And then at the very top, you can see the supraspinatus coming across and inserting on its footprint, this flat line, before it turns into the kind of the ball side of the joint. And it should kind of have a uniform gray to black appearance. And so the black is more healthy tendon, the gray is irritated tendon. And then at kind of this top left corner of it, you can see that there's white that goes through it. And so this is a partial thickness bursal sided tear, meaning that the tear affects the top half of the tendon, the side that's closer to the bursa, but it doesn't extend all the way down. And in this one view, I can't tell you what the width of it is. I don't know how much tendon is involved. I can just say, yep, there's a part of it that has a tear in it. And again, going back to thinking about the shoulder holistically, all of the structures that are involved in the mechanisms of the shoulder, you can actually see that acromioclavicular joint here that's quite arthritic. It has white inside the bone. So even the bone is starting to get irritated by the stress of the arthritis. And that's just one of the things that we always look for is what's the other contributing pathology? What are the other things that are involved? Not just the tendon, but the kind of the shoulder joint as a whole. The point that I want to make with this ultrasound is you can see bright white. This is bony contour. So that's the humeral head. You can see this flat line here. That flatness is the same flat area or footprint that we can see on the MRI. And you can see the full width of the same tendon that's being depicted in the MRI. And so under ultrasound, we get about a 3 times magnification over what MRI does. So we're better able to see some subtle pathology within the tendon. And that can help determine our plan. And then whenever we do treatments, we're able to have much more accuracy in treating exactly where the pathology is because we can see it under the MRI. And so what I want to do is get into talking a little bit about treatment. And just like there's a spectrum of pathology, there's a spectrum of treatment that many people try for the shoulder. And so we're going to go kind of quickly through a couple studies that I wanted to highlight some of the key points from and talk about kind of what all treatment options exist and why some are maybe better than others. So the first one is this study that came out fairly recently, 2020. This is an arthroscopy journal, which again is a surgical journal that published this. And this is a US study with really quite big universities behind it. If you look up the authors on this, they're coming from universities like Tufts, Rush, Hospital for Special Surgery, and again, being published in a surgical centric book, but they did a review of corticosteroids and how they affect the rotator cuff tendons. And so, I took this quote out from the article because it's really pertinent. And so, to read through it, CSIs or corticosteroid injections decrease cellular proliferation, alter collagen and extracellular matrix composition, impede inflammatory pathways, decrease cellular viability, increase adipocyte differentiation, and increase apoptosis. And it happens as soon as 24 hours after injection. So what do all those mean? I actually want to go through and talk about each of those. So what is cellular proliferation? It's the ability of the tendon to heal itself. It's the ability for marrow cells, stem cells to come out from the bone, migrate to the area that's being injured, and try to have a healing effect. Collagen and extracellular matrix composition. The tendon structure changes after corticosteroid injection. It becomes less tendon-like. It can become, it goes through a process that's called metaplasia, meaning it looks more like cartilage actually than it does look like tendon. So the steroids change that actual structure of the tendon, which is one of the reasons that if you see a Regenexx doctor, we're often going to ask you, tell me about your prior steroid exposure, because it's changing the tissues, changing the substrate of what we are working to heal. It impedes the inflammatory pathways. That's what steroids really do a great job at. They stop inflammation. And there are certainly medical conditions in which steroids are warranted. But in the musculoskeletal realm, the inflammation is our first step of healing. And so we actually want to have some of that inflammatory response. And if anyone follows Dr. Centeno's blog, he wrote a really, really nice one just a couple of days ago about how anti-inflammatories impede that process and are more likely to actually cause chronic pain. So I'd certainly recommend checking out our Regenexx website and Dr. Centeno's blog in that regard. Decreased cellular viability, that's kind of what it sounds like. The cells are less healthy, so they don't live as long. Analogy I often use with patients is it's like being in a busy office with noisy coworkers and bad music. It's harder to do the things that you're required to do when you're in this kind of nasty environment. And so the cells become less viable. They don't do their work. They don't live as long, which hurts the tendon long term. Adipocyte differentiation, what's that? It actually makes the cells in the area look more like fat cells. And one of the things that we look at as far as prognosticating or predicting outcomes of rotator cuff injury and treatments is we look for atrophy, but particularly fatty atrophy. So fat will infiltrate into the muscle. And when it starts to do that, the muscle becomes less effective. And so it's harder to then rehabilitate the tendon. Steroids push us more in that direction. And they increase apoptosis. So going back to some of the other things, not only do we have less cells in the area that are trying to heal, not only is the thing that they're trying to heal less structurally sound, and not only are the cells really not doing their job, but apoptosis means that they're killing themselves early. So cells all go through a natural kind of life cycle. And this process of apoptosis is the cell saying, I'm done, and it actually kills itself. And so this is kind of the detriment of corticosteroids, which oftentimes is kind of the first step when you go to see, a general musculoskeletal physician. They say, oh, let's try steroid and see if it calms you down. But not only is it not effective, it's actually hurtful, and it's something that can hinder progress in the future. Moving on to the next one, when we kind of talk about rotator cuff tear surgery, we look at the difference between operative and conservative management. So this was a nice study, randomized patients, put them into a physical therapy versus operative therapy, and it found out that there's essentially no difference between surgical and physical therapy outcomes. And so that's kind of interesting because we use physical therapy, or surgeons use physical therapy as a gauge. Hey, you didn't get better with physical therapy, let's do surgery. But the outcomes are the same. And so if if we didn't have success with one treatment that has X percent of improvement, then why would another treatment with the same X amount of improvement kind of do any better? And so I do think there's a place for physical therapy. It can be helpful, but in some cases it's not enough, and we need to do a little bit more to make the tissue healthier. And we're going to talk about that just a little bit later. Again, we talk about, is the surgery helpful? And it's about as helpful as physical therapy, but it also has some detriment to it as well. So this is a nice study, lots of patients, 500 consecutive patients by the same surgical group, looking at what was their re-tear rate. And so the average, when they looked at it all together, they found an average re-tear rate of about 20% by 6 months, which is very quick after surgery. And if you ever know anyone who's had rotator cuff surgery, at 6 months, they're still quite sore. They're not even back to full go at that point. And this study, the average skews a little bit low to the lower side based off of their breakdown of how big the patient's tears were. And so what they found is the bigger the tear, the more likely you were to have failure. Actually in this study, going up to about 60% re-tear rate on the larger size tears, but there's been other publications that show a 90% tear rate with the larger size tears. And another finding is that if you're over the age of 60, roughly a third of those surgeries are going to fail to heal at 1 year. And so, and that's kind of regardless of their tear size. So the question then becomes why? Why is this not so successful? Is it because of surgical technique? No, our surgeons are brilliant technicians. That's what they do. But the foundation is what's really flawed. So looking at this great study, Philippe Hernigou is essentially the French version of Dr. Centeno. He's an excellent scientist. He does a lot of wonderful research in the realm of regenerative medicine. And what he found on biopsy studies was that when we look at the concentration of mesenchymal stem cells, or MSCs, we see that the biopsy concentration in patients that have tendinopathy and rotator cuff tears is much less. So what does that mean? That means that, again, all of the things that we talked about with the tissue being less viable, the structure itself being changed, and the cells that are naturally in all of our bones, from the shoulder down to the little bone that makes up the end of your pinky, are less able to go to that site and make the repair. So when we kind of go back and in our heads, we think about that early picture that I showed with the big rotator cuff tear, and that one had some sutures in it. What we're essentially doing is taking tissue that didn't heal naturally because the body didn't have the capacity, it didn't have its natural regenerative ability, and we're just approximating the ends of tissue that's not great. And so it's already torn, the tissue doesn't have that capacity, and we're saying, oh, well, we hope it'll heal because we made them neighbors, right? We took one end of the tendon, put it next to the other end of the tendon. And in some patients, it does, but that's not the case for everyone. And so we look at ways that we can kind of get better outcomes. And that's where our treatment comes in. We kind of have a little bit of a different approach to it. And when we compare kind of what our treatment looks like compared to surgery, we can see a change in outcomes. And so this is a comparison of one of our treatments using SD, which is our same day bone marrow treatment or stem cell treatment, versus typical surgery. And so when we look at time, just getting back to your typical day-to-day stuff, in our patients, we see about 2 to 5 days. I typically say 4 to 5, but it's going to be somewhere within that first week. In surgery, you're going to be out quite a while. I trained in sports medicine at the University of Pittsburgh. We saw lots and lots of surgical cases. Many patients were saying that not only were they not back to activity, but many of them were sleeping in a reclining chair for the first couple months because it was so uncomfortable. We're getting our athletes back to high-level sports within about 3 to 6 months. Surgery, it's at least a year out, and the recovery is quicker when we use the natural bone marrow cells or stem cells from the hip, for several reasons. One, we haven't violated any tissue that's already in the body, so we haven't changed your native biomechanics. We haven't had to break the skin, and we don't do extensive bracing. We do sometimes put patients in a sling, but that's really only for a couple days, and then we're getting into physical therapy because we want to get that motion back. We don't want to get stiff. Again, if you've known anyone that's had shoulder surgery, one of the common complaints is the stiffness that they have afterwards and the lengthy physical therapy that they have to put in to get their motion back. Pain management is also easier after a procedure compared to surgery. That one kind of conceptually makes sense. Many patients do great just with over-the-counter stuff. I typically do prescribe a little bit of pain control beyond that, so it's available. But many of my patients come back and say, I really didn't need much of it. The pain went away. And we also have other techniques that are helpful in managing pain that typically we don't see in the surgical setting. So for an example like this, a rotator cuff treatment, it's not uncommon that I'll block a nerve in the neck that'll kind of numb up the whole arm, and that lets the patient kind of recover that day, get more sound sleep that night, and then certainly the post-procedure soreness can set in at that point. But it's a nice kind of option for controlling pain that doesn't require like narcotics or opioids. We don't do our procedures under anesthesia in which you're unable to breathe for yourself, but we do offer sedation in patients that want to do that. And so that's twilight sedation. It makes you sleepy, makes you kind of forget about the pain, and it can make the procedure very, very tolerable. Whereas with surgery, yeah, you're going under general anesthesia. You'll have a nurse anesthetist or maybe an anesthesiologist kind of running your case, and there's risks with anesthesia as well. And then kind of like I said, you're keeping all of your native tissue, kind of what you had, you will continue to keep. Whereas with surgery, it's not. You will have sutures, you will have anchors into the bone. And so the kind of post-surgical change is going to be a little bit different. And so I could show an example. This is a nice case study. It's a little bit of an older one, but the picture is really, really nice. And we can look at kind of what it shows here. We're seeing that same ball and socket perspective looking from the front of the patient. Just above the ball and socket is the tendon, again, inserting on the flat piece of humeral bone, which is the supraspinatus footprint. And looking at the picture on the left, this is a pre-treatment. So this is an injured shoulder. We see lots of fluid in that same bursa that we looked at before. Some of this may be contrast, or maybe it's the irritation that they have from this tear. We see a fairly large sized rotator cuff tear. maybe there's some, deep fibers that are still intact, but quite large defect through here. And then when we repeated this study about the MRI 11 months later, we're seeing a filling in of that defect. The bursal fluid is all gone. We don't see quite that irritation. Even in the glenohumeral recess, a pocket in which fluid can collect, we don't see any fluid through there. So we're able to kind of fill that in using our bone marrow treatment and getting the patient some structural change. But more importantly, it's how do they feel? And so one of the studies that we did at the clinic, large randomized controlled study that had what's called a crossover effect that I'll mention later because it is important. We're looking at their DASH score. And so this is patients that were treated rotator cuff tears, partial and complete, using bone marrow concentrate or stem cells. The DASH score is a disabilities of the arm, shoulder, and hand. It's a great metric on looking at how much are we improving the patient's ability to do the things that they want to do. And it looks at ADLs, your daily living type stuff. It looks at functional abilities. It looks at sports. And so in our physical therapy group, which is our top one, we saw a mild decrease, but it took about 6 months for it to become statistically significant. And 6 months is a very, very long time to be in physical therapy. And this study was what we call crossover, meaning the patients that were in the physical therapy group were not blinded. They knew they were doing physical therapy, but they had the option at 6 weeks to say, yeah, I'm happy with my progress. I don't need further treatment. Or they could cross over and go into the treatment group with injection therapies that we do at the Regenexx clinic. And so they could fill into then this group. And what we see in our patients is that really after the first month, we see marked improvement. Their DASH score, which again is disability. So the higher the score, the more disabled the patient rates themselves. The DASH score drops drastically to well under 5 by a year out. And for most of our treatments, we see that this is sustained. So it's not the steroid effect where it's a quick on, quick off. It's an improvement that does take some time, but again, much faster than physical therapy. And it has sustained improvement because again, you're keeping your native biomechanics. We're actually repopulating the area with the stem cells that can help with the healing process. And that's what gives us kind of the longest lasting results. And so this is kind of one of the things that we offer and I like to talk to patients about. Again, I do think it's an awesome treatment, and we look at kind of the patients that are good candidates. Certainly, very, very large tears, retracted tears. We do have some patients that are not a candidate for our treatment, but having kind of the musculoskeletal expertise with the regenerative medicine and doing a complex musculoskeletal exam that includes point of care ultrasound on the visit day gives us much more information, and we can make some decisions at that time about what would be most beneficial. So that's kind of our talk as far as the shoulder goes. If anyone has questions, please write them down into the chat box. I'll go through those. If you have if you have shoulder injuries and you want to be evaluated, you can give us a call at the clinic. And then certainly you can ask me questions through my email as well. And also, if you have ideas, things that you want me to talk about, topics that are important to you guys, please let us know. Email me, and we'll start to include those in our webinars as well. So I'm going to stop sharing the screen, and we're going to go through kind of the chat box and see if there's any comments. And certainly, if anyone has questions, I'm happy to entertain them. We'll give a couple minutes for anyone that wants to write in. Oh, I got it. So we've got a good question. So Steve is asking, I have arthritis in my shoulder. Can I still get treatment? Absolutely. And so it's common that we see arthritis in the shoulder as kind of part of that whole complex. And like I said, we're really looking at the shoulder as kind of a whole organ. What all is involved? The cartilage, the ligaments, and the tendons all play a part of that. And so, yes, I think you'd be a good candidate for that. And one of the things that we know is if we can increase the stability of the shoulder, which happens through two processes. One is the ligaments. Ligaments are static stabilizers, meaning they're like chains. They hold bone to bone. So treating the ligaments to get our static stabilizers up, but also treating our tendons, which are part of our dynamic stabilizers, which means that with motion, they're what kind of controls the joint. By treating all of that will help with the arthritis as well, because now it's not like having loose struts on your car where everything's moving around. We're able to kind of hold the joint a little bit closer together. The other thing Steve, that your question kind of reminds me of is, one of the things that I see very, very commonly is that neck pain is a cause for their shoulder symptoms. Oftentimes patients will present with pain down the inside of the shoulder blade or rating across the trap. And so that typically tells me we need to look at the neck as a potential cause too. So what we see commonly is that if the nerves become irritated in the neck, the rotator cuff muscles are less able to fire in kind of their organized way. which leads to tendinopathy. So the tendency is more stressed because the muscle's not doing its job. And so you can, I'll often use the analogy with my patients. This is the flickering light bulb in your kitchen. You can change the light bulb, and that might be part of the cause, an older light bulb, or you have to go look into your garage at the breaker box. And so there may be a problem with the actual signal coming to that area. And so by treating both, we see better outcomes. And so great question, Steve. Thank you for contributing that. All right, well, if no further questions, we will kind of call it a day for our webinar. We're going to be trying to do these basically every other week around this time. I think our next one, we're going to be talking about low back pain and everything that involves, from disc disease to sciatica. What is sciatica? What's radiculopathy? What's piriformis syndrome? How does all of this stuff kind of play together? And what can we do to kind of help out patients with these symptoms to potentially save them for surgery? So again, if anyone has questions, you're welcome to email me or call our clinic with both the number and the email address that I showed. Otherwise, I'm looking forward to seeing everyone in a couple of weeks. Hope you have a great day.